There for Care is brought to you by CareScout with the goal of sharing real-life conversations about aging care. Views expressed on this program are the speaker's own. We do not provide medical, legal, tax, financial, or other professional advice. Always talk to your own professional advisors for advice tailored to your needs.
Welcome to There for Care by CareScout, a podcast all about navigating aging care, whether for yourself or a loved one. My name is Katie Boyles, and today we are welcoming back Dr. Aaron Rosenberg, the Chief Medical Officer at Genworth and a board-certified internist with over 20 years of experience in healthcare leadership. He has spent his career caring for aging adults, and today he is going to break down the emerging Alzheimer's and brain health tools, what they can do, what they can't do, and what we should care about. And now, as a disclaimer, we are not providing any medical advice. You should always consult a medical professional for your own personal situation. Thank you so much for joining us today.
Thank you for having me back.
Yes. So with so many headlines and breakthroughs in Alzheimer's and brain health, how should we be thinking about what actually matters and when somebody should look into these tools?
Absolutely. Well, the best thing is, I think, break it down into two questions. What is this tool? And when is it supposed to be used? So I think if you look at all of the developments from that perspective, it's going to help you decide what's relevant and what's not. Many of these tools are very stage specific, and it's important to identify when they're most ideal to put in practice. And, just a little bit about my perspective on things. So my position at Genworth, I take care of really the life cycle of a policy, from underwriting to the pre-claim period to claim. And that roughly mirrors sort of the aging journey. And so I always want to keep in mind when the tool is best applied for the best outcome. Right tool, right time.
All right. So GLP-1 medications. They are all over in the media. People see them all around. And these were drugs originally developed for diabetes and are now widely used for weight loss. So they are also being discussed in the context of Alzheimer's and brain health. Why did researchers even think these drugs would matter for our cognition in the first place?
That's a great question. So dementia has its risks that really start in midlife. And many of these risk factors begin long before symptoms of cognitive impairment start. And the nexus is really vascular health, inflammation, and that's where the nexus for the GLP-1, since there's an intersection with many of those risk factors. They were originally developed for weight loss and diabetes, and they affect insulin sensitivity, but there also is a vascular protective effect and an anti-inflammatory effect. And that's where the initial interest sort of developed, that these may have an impact on dementia. But preventing dementia and treating dementia once it's occurred are two different things. And even though the hypothesis, I think, is justifiable, it just simply may not be the same pathways for prevention as it is for curing a disease process.
And so several studies have now looked into this specifically for people with Alzheimer's. What are those studies showing? And just as importantly, what are they not showing?
Well, GLP-1s are not effective currently for the treatment of existing Alzheimer's disease. Now, that doesn't make them irrelevant or even ineffective. I think what it really focuses us on is that these tools may be most appropriate further upstream. And that's where we previously talked about the Lancet Commission in the last podcast that I was here. Thank you for that, where we talked about 14 different risk factors that represent about 45% of mitigatable risk of dementia. And many of them start in midlife. So the fact that these GLP-1s didn't change the course of existing disease doesn't make them irrelevant. It simply means that they have probably the best utility in the prevention space instead of the curative space. It's sort of like chasing after a train that's left the station, right? The effort's not wrong. It's just the timing is not ideal.
So if The GLP-1s don't change the course of someone who already has established Alzheimer's. Is there still a role for them when it comes to the dementia risk more broadly?
More broadly, at a population level, absolutely, right? Because we are impacting the vascular risk factors and the inflammatory risk factors, the cardiovascular risk factors, and all of those have a nexus with the established risk factors that we've already talked about from Lancet and otherwise that affect the ongoing predictability of cognitive decline later in life. So when you're able to prevent some of these things from manifesting across your lifespan, you really decrease the risk of developing cognitive impairment later in life.
So another area that people are talking about right now is blood tests related to Alzheimer's. Can you share more about what people are looking for, what they don't find from those?
Sure. So there's two blood tests that have been FDA approved. And I think this is a popular topic because the most recent one, which is Roche's Alexis test, was approved in October of 25 for primary care. So a lot more people are going to be exposed to some of these tests, either through discussion or advertising. And, I think it's a relevant topic. Now, I'll start by saying neither one of these tests diagnoses Alzheimer's disease. These tests are intended for people that are 55 and up and already have existing concerns of cognitive impairment. So they're not a test for everyone. And I think the virtue of these tests is when you're considering perhaps looking into some of the treatment options that exist for dementia with the anti-amyloid therapies. That means you undergo a lot of testing, and some of that testing may not be close to your house because it involves sophisticated PET scans or lumbar punctures to test for amyloid. These tests can tell you whether you have the biologic underpinnings of Alzheimer's disease, but they do not make a diagnosis. And probably the best utility, especially for the Alexis test, is when that test is negative. So it has a very high negative predictive value, which means that if it's negative, it really does mean that you don't have the biologic underpinnings, either tau or amyloid, in the brain that would justify potentially looking for a diagnosis of Alzheimer's disease. The problem is that when these tests are positive, you still need to continue the conversation. You can't stop there because it's not really going to be meaningful in a sense of getting to a diagnosis. All you're going to find out is that you have some of the biologic underpinnings of Alzheimer's disease.
Okay, so we've talked about medication and also diagnostics, but care itself is changing too. And Medicare recently introduced something called the guide model for people living with dementia. What is that and why does it matter?
So the guide model stands for Guiding an Improved Dementia Experience. This is a Medicare-funded pilot for 8 years. It began in July of 2024. Now, this is probably one of the biggest, if not the biggest, expansion of dementia healthcare benefits in Medicare, certainly in recent decades. The virtue of this program is that we are understanding that care should be moving upstream. Just like we talked about midlife risk factors and things of that nature, the guide model also is moving care upstream because what they found is that when you have significant symptoms, you're often responding to crisis or a higher level of care in an immediate fashion, and that can get very expensive. And sometimes you may not have all the information you need to make an informed decision. So what this guide model does is it connects care providers in addition to people that are suffering from dementia, either mild or moderate or even advanced dementia. And it allows them to have a longitudinal care model where you not only can have access to 24/7 care providers, but you have care planning, you have medication review, you have interfacility guidance, and not the least of which is $2,500 in respite care to prevent caregiver burnout. And all of this is zero cost sharing, which means it's free to patients and their family. And that's with the only exception being the initial visit to diagnose dementia with a guide healthcare provider. But beyond that, all of the care provisions are free. So while it's not a cure for dementia, it certainly can be very meaningful to prevent acute crisis and maybe expensive decisions where you don't have all the information when you have severe symptoms that manifest. So I really do think it is an opportunity for people to look at the pilot program for Medicare. There are a few caveats that I'll mention. You have to be in traditional Medicare. You can't be in hospice. You can't be in a nursing home or something called the All-Inclusive Care of the Elderly, the program of its abbreviated PACE. But besides those exceptions, people with traditional Medicare really have an opportunity to have a much broader continuity of care within the dementia experience.
Okay. And so what do you want the people who are listening right now, who are caregivers, to know about emerging treatments for cognitive decline in the future of dementia care?
Well, I think that any current and recent sort of news brief on care can really have a lot of interest because there's a tremendous amount of sort of unmet need in aging. And it becomes helpful to put that in context. And I think immediately what you want to think about is what is this tool used for and when is it best applied? And if you can start by asking those two questions, it can help you understand whether this development is meaningful or not. I think what's important about developments is we've gotten a lot better. We've gotten a lot better at defining risk, at treating those that are affected and impacted, and mitigating a lot of sort of the downstream risk that can occur. We don't have a single solution yet, but we are much better at helping people along the aging journey. So I think what becomes important is that you're not alone. And there are many different tools now, and just finding where they're most applicable is the most important step in the process.
Yes. Well, thank you so much for joining us back and for sharing with our listeners some more information that they can use to help with either themselves or a loved one.
Oh, well, thank you very much for having me.
Yes. And if you would like to see the last episode that Dr. Rosenberg was on with us, we will have that linked. Be sure to like and subscribe and send this to any friends or family who you think could benefit from the information. We'll see you next time.